Good afternoon, Mr. Chairman, dear colleagues and professors. I know it's too late, but first of all, I would like to thank Professor Muhammad Sobhi who gave me the chance to be here in this elegant meeting. Before I introduce this case, please remember the address of the presentation, point of no return. This is male patient, 67 years old. He complaining of shortness of breath, dyspnea, paroxysmal nocturnal dizzy, and lower limb edema. And clinically, he is conscious, orthopnic. His weight is only 50 kilogram, and his blood pressure was 90/50. His heart rate high, 100 beats per minute. And he has bilateral diminished air entry at her basal lungs, and he was admitted in the intensive care unit with cardiogenic shock 1 month before this admission, complaining of severe chest infection and intubated for more than 2 days. His creatinine level was 1.9 and his hemoglobin only 10 milligram per deciliter, and he has elevated liver enzymes. And you can appreciate here he has slight astigmatic deviation, depression in the infralateral leads, starting from V4 to V6, and he has significant left pleural effusion. And this is his echocardiogram, and you can appreciate here he has only ejection fraction about 30% with mild to moderate mitral regurg. And he has severe aortic stenosis. Although he has severe LV dysfunction, but his gradient, the mean gradient was about 50 millimeter mercury. And this is his CT. This is the first problem. He has bicuspid aortic valve type 1, and his mean annulus diameter was 22. So the plan to go with evolute R26. But we have to measure the annulus more because this is bicuspid aortic valve. So usually in every bicuspid aortic valve, I do prefer to do pre-dilatation first and to assure the sizing of the valve. But this is the second surprise. You can appreciate here severe LV dysfunction. He has severe calcific left circumflex lesion. This is not stent, this is a calcification. And he has middle lesion at the LAD. And this is his risk scores, very high, for mortality, for morbidity, for long stay in the ICU. This is ST score and Euro score. So this patient is very high risk for surgery. So how would you treat this patient? Can we open the discussion?
I assume that this patient is considered high risk for surgery, so the surgeon will maybe said not suitable for surgery. My question is, of course you need to treat the aortic valve, and your plan sounds good. My question is about the coronaries. The patient has no angina or is a kind of stable angina. And I like to see the NT again. As the circumflex seems diffuse long region, we usually, unless the patient has real severe angina, we are very conservative. So I like to look on the LED, but my threshold to treat the coronaries will be relatively high, and maybe I will skip a PCI on the coronaries. Everything else is fine.
Uh, yes, I think we have to treat aortic valve, but I think we have to treat also coronaries. And I prefer to treat for this patient first of valve to see how it's going, if the ejection fraction is increased, and also we need to evaluate stigma, provide he has lower average function. The only reason is aerosols or coronary. So I think you want to go additional that.
Can I ask a question? Because I think we probably know what you're leading to. What is your impression about the coronary of this patient? Do you think this patient coronary need to be intervened with? Let me give you the question with another scenario.
This is
Let's assume the patient has no aortic stenosis and you have this coronary. What will you do?
I will treat it.
You will treat it.
Yeah.
How many of the audience will actually agree with you?
And they really agree. How do you do it? You treat it.
If there is no aortic stenosis and you have these coronaries, you will treat it or not? He has
He said no angina.
at the presentation of at this presentation he has no angina, but 3 months before he has chest pain.
Yeah, but the ejection fraction can be lower
Yes.
than the aortic stenosis.
As long as
Or it is aortic stenosis.
as long as study is not used for bypass valve, I suggest to use the balloon valvuloplasty to reduce the upset load and then push the IV function and the symptoms.
It's a good point.
But you do the coronary first. You don't know it. Two questions. You touch the coronary and then you go to balloon, or you direct to the aorta. There's two opinions here. One is stable angina, leave the coronaries, go for the aorta. Or when you go for coronaries, go for the aorta. What do you do?
I go for the aorta first.
Any suggestion?
You know, Dr. Sobhi, I think he is raising a very interesting point. Do you have actually to know how vital the myocardium is in this patient to treat it away now? I don't know. It's a very important point. I mean, how many would like to know that?
It seems like it's stable coronary artery disease. So I guess to go to the aortic valve to fix it.
I believe this suffers WGOD, valvular stenosis, and post-coronary heart disease. If we have evidence of ongoing ischemia, like chest pain, like neck lesions or enzymes, then ischemia may have a great role. So we can, to prove that there is ongoing ischemia, we have to tackle the coronaries as well as the aortic valve.
Okay.
The idea that you are dealing with a very complex, sick, cardiogenic patient, so cardiogenic shock patient. So I think having these lung infections, having this lung compromise, there are multi-organs, his creatinine is up. So he's a very complex patient, and I think thinking of the aortic valve valvuloplasty as a temporary solution to look at what's the situation, and then assess. In my book, doing the PCI for calcified LND and SERV with a reduced EF is another way of sending him upstairs. So I don't want to be sending him upstairs. I would like to help him as much as possible. And I would think maybe putting an umbrella if I do the valvuloplasty and do the vessels and then do the final aortic valve replacement.
This is
So
very.
what's the heartbeat said?
This is very good point, but we haven't umbrella in Egypt. Um, um, My thought that this patient should have a balloon dilatation first. And the balloon dilatation should done during rapid pacing. And if this patient had two vessel disease as codominant circumflex and LED, during rapid pacing, patient may collapse. So our thought that to treat coronaries first, and then if the patient tolerated the procedure, we will continue to do just balloon and see how the LV function will behave after that, or we will proceed to TAVI directly. But let's see, this is our team, and this is our plan, and this is first BCI to LCX, but at the time there is no time to bring rotablation, and we thought that this is calcium should be treated with special balloons, cutting balloons or something like that, but unfortunately this is undilatable lesions. This is the first surprise. Multiple balloon inflations, but we got this. And the action started. The patient more collapsed, and we stopped what to do. So I thought that I will transfer this patient from two vessel disease to one vessel disease, and I will treat the LED. And I did very good pre-dilatation for the mid-LED and stenting and post-dilatation after that, and the LED, this is the final result as you can appreciate here. And my wish at that time to stop here, but what happened? Respiratory distress, hemodynamics were compromised, blood pressure was 60 by inotropic support, huge doses of inotropes, and the patient put it on mechanical ventilation at that time. And no considerable improvement was achieved. So, this is my point of no return. This is hemodynamic instability, suboptimal coronary vascularization as you can appreciate the circumflex as you see, and this patient has a significant aortic stenosis with severe LV dysfunction. So I took the decision to do balloon aortoplasty. The second surprise you can see here, the aorta non-dilatable, and I used 18 millimeter balloon and not inflated well, so I upgraded to 20 millimeter balloon. But what happened here after balloon dilatation? The patient arrested. And this patient returned again when I drew everything outside, but the blood pressure still 70, and we decided to go with the wire again and inflate the aorta, and we'll see what will happen. The action continued, so I took the decision to do TAVI, and this is 26 millimeter balloon. And you can't imagine, this patient arrested more than 15 times. Every fine touch for the LV by anything, by balloon, by wire, by everything, the patient went to arrest for 7 minutes and then come back. And you can imagine this patient, the duration of procedure was about 4 or 5 hours. And I obliged to open the valve during the CPR. And this is the final release, as you can see here. And here, this is the final result. There is no aortic regurgitation, but still the patient the hemodynamics of the patient compromised. And this is his echo after 15 minutes from the procedure. And this is his 2 minutes.
It's not upstairs. Gordon is not upstairs.
Hemodynamics improved dramatically, transferred to cardiac unit, liver enzymes and creatinine so high in first 2 days, but after that all laboratory results corrected and ventilator weaning was performed. And this is his echo, day 3 post-operative. As you can see here, his LV function improved and reached above 40, and there is no aortic regurgitation, as you can appreciate here. Discharged at day 9, and this patient doing well for 9 months. He sent me an echo because he's not Egyptian. He sent me an echo that 1 week ago he told me that he has normal LV function. So my take-home message: decision-making in high-risk individuals with multiple comorbidities is both a science and an art. Procedure success critically depends on a proper selection, meticulous pre-planning, experienced teams, interventional and surgical, and well-equipped units. This is very important. A good TAVI operator is simply not enough. So the elephant is in the room. Now we have TAVR options for those who had no TAVR option. But what we will do for those are high risk for TAVR? In fact, we had a lot of lessons from such of those cases, because if I faced this patient again, I will not do the scenario like this. Thank you.